Bismillahirrahmanirrahim. Assalamu alaikum. I'm Dr. Zia. I welcome all of you from Master of Medical Knowledge Hub for today's lecture of fluid balance in surgical patients. Fluid balance is a very important aspect in perioperative management of surgical patients. Now, next question is we know that what are the causes, what is the composition, how we have to replace the fluid, what are the fluid available for the resuscitation purpose and in the maintenance therapy. Now, next question is what route to be used? As in normal health, oral route is the preferable route. However, when the rapid correction of the hypovolemia is required, along with the electrolyte abnormalities, we have to rely on the intravenous route. Other routes which can be used for the parenteral therapy, these include the subcutaneous routes, perrectal route, and the intraosseous route. But the most reliable and most efficient route in case of the for the fluid resuscitation and fluid replacement is the intravenous route. This is the same fluid charts which we have discussed previously. Just these tables are summarizing those formulas and parameters. Now, when we are balancing the fluid in the preoperative period, we have to keep in mind one terminology, that is the third space losses. And we have to correct the third space losses. This we will discuss shortly. Then we have to correct the sodium balance. As we know that sodium is the major extracellular cation and responsible for the osmolarity of the extracellular compartment. And third is the potassium. Whenever we have to correct the potassium with the supplements, the adequate urine output should be maintained. Because if the potassium is not excreted by the kidney, excess of the potassium is not being excreted by the kidneys, it will lead to the hyperkalemia and it can lead to the arrhythmias. Must check if there is hemorrhagic cause. So blood replacement must be there available and it must be replaced with the blood. Blood must be replaced with the blood. Calculate the allowable blood loss and prevent the volume depletion. So these are the special consideration in the fluid balance in preoperative period. What is the third space? Third space losses is very important. Isotonic transfer of extracellular fluid from the functional body fluid compartment to the non-functional compartment. What are the functional compartment? These are the intracellular, interstitial, and intravascular. Or if you label into the two spaces, one space is the intracellular space, second space is the extracellular space. If fluid is not lost in the intracellular space or the extracellular space, it means it is being lost in the some non-functional compartment, and then that non-functional compartment is the third space. It depends on the location and duration of the surgical procedure, amount of the tissue trauma, ambient temperature, and the room ventilation. So these third spaces, for example, if the fluid is lost in the peritoneal cavity, it is not in the intravascular space, it is not in the interstitial and intercellular space. So it is the third space. Any potential space which is non-functional for that fluid is the third space. So how to replace the third space losses? If there is minimum trauma, 3 to 4 ml per kg per hour, for moderate trauma, 5 to 6 ml per kg per hour, and for severe trauma, 7 to 8 ml per kg per hour. Surgeon must remember that by the 72 hours post-operative, this third space become mobilized, which results in increased intravascular volume. That this non-functional fluid will be again shifted to the functional compartment in 72 hours. And at that time, this must be taken in consideration to calculate the fluid requirement of the patient. What is the blood volume? In total body fluid, is the 600 ml per kg in men and 500 ml per kg in the women, total amount of blood. And the whole blood is 66 ml per kg, and the plasma is 40 ml per kg, and erythrocyte is this is the chart is comparing the total body fluid with the amount of the blood, plasma, and erythrocyte in the male and female. Intraoperative fluid management. This we will discuss. That if preoperative volume deficit is not addressed, patient will lead into the hypotension. Third space losses should be addressed, as we already discussed. But there is no lab method which exactly quantify the fluid loss. So clinically useful guidelines should be applied, that the replacement of the extracellular fluid should begin intraoperatively. Blood should be replaced to maintain the acceptable RBC mass, and there is the balanced salt solution needed intraoperatively. In post-operative management, in first 24 hours, as we have discussed, there is the conservation of the sodium and there is the water retention due to the increase in the aldosterone, renin-angiotensin-aldosterone system, and antidiuretic hormone secretion. So we have to give the sodium-free fluids in the first 24 hours to the surgical patient in post-operative period. If blood loss is there, it should be replaced. If there is fluid deficit, it should be replaced with the dextrose, normal saline, or ringer lactate, but not the purely saline fluids. Should not administer potassium unless definitive deficiency is present, because potassium is very sensitive to the cardiac muscle. From the first day to the second day, replace the insensible losses, which may vary from the 900 to 1500 ml per hour, which can be due to the hyperventilation, fever, tracheostomy, and loss is replaced by the dextrose normal saline. After second day, from 48 hours onward, replace the insensible losses, and better to give the isotonic dextrose normal saline or the ringer lactate. Replace the potassium loss if it is particularly required. Post-operative fluid management. This is the summary that we have to maintain the intake output charts. Output include the urine, vomitus, aspiration with insensible losses and sweating losses. And intake is via the oral route and via the IV route. And this chart balance should be maintained. Post-operative urine output. Oliguria is common in immediate post-operative period due to these factors. And if there is the persistent oliguria, patient may go into the hypervolemia. So urine output less than 0.5 ml per kg per hour for 3 or more hours is indicative of the acute renal failure. We should be aware of it. What are the end parameters for the fluid replacement therapy? This is summarizing those features: central venous pressure, pulmonary pressure, cardiac attendance, and blood lactate and base deficit level. Thank you very much for today. Next time we'll meet in the next topic. Thank you very much for today. Next time we'll meet in the next topic.